Well, hey everyone, I am sitting down today to speak with Jason Almiro. Uh, Jason is someone I met earlier this year. I think this is going to be a very interesting discussion because we're going to talk about money, in particular, the Medicare Physician Fee Schedule. A little bit of background. Let me give a little bit of background on you, Jason, and then if you want to chime in, go ahead. Uh, Jason, by training, is both a CPA and a chartered financial analyst. He's the founder and the managing director of a firm called Quantum Health Advisors, which provides accounting, financial, disputes, advisory work exclusively in healthcare, with working with healthcare providers as well as with payers. And so he advises on a number of complex issues, including, as we're going to be discussing, reimbursement, payer contracting, and so on. Uh, Jason, is there anything else I sort of should mention about your background, or is there something you want
No,
to
that
add to
was
that?
spot on. I
Yeah.
appreciate it. And
So
thank you for
what I
having.
what I'd like to talk about, and actually I'd like you to talk about because you're the expert on this, and I'm honestly not. It's basically the 2026 Medicare Physician Fee Schedule and what sort of healthcare leaders and clinicians need to know at a high level about what the upcoming year is going to be like. So why don't we start, very basic, which is what is the Medicare Physician Fee Schedule and what sort of headline changes arrive starting in 2026?
Sure. And first and foremost, thank you for having me. I
Oh,
appreciate it.
sure.
It's an honor. So before I get into it, I have to the physician fee schedule is the mechanism that Medicare uses to basically calculate physician payments across, hospitals, office settings, and outpatient settings. Okay. So I do have to get into the weeds a little bit.
Okay.
As you might expect, there's a formula, and I'm going to try to simplify this for everyone out there. Is that you, on one hand here, you have these what they call RVUs, okay? And that basically compensates physicians for their time, their effort, their overhead that they incur for hiring staff, right? And then their malpractice insurance. So there's three buckets in this RVU world, okay? The work RVU, which is the time you could think of for the physician spend. And then this practice expense, again, it's the overhead to compensate physicians for their overhead and then for their professional liability insurance. So you got that on one hand. And then on the other hand, you have this conversion factor, which basically makes all these RVU numbers into dollars. And that is how physicians at a 50,000 foot level
Mhm. Okay.
get reimbursed from the Medicare system. And now to back up for 1 second is CMS, the body that regulates the Medicare and Medicaid system, um, puts out pronouncements twice a year. They come out with their draft announcements earlier in the year, and then later in the year, they finalize them
Hmm.
and they make changes. Sometimes they say physician payments are going to increase, sometimes they're going to decrease, but the devil is always in the
Yeah.
details, as you might suspect.
Hmm.
So you asked what a couple of the
Yeah.
now keep in mind this document I think is close to 1,000 pages long, the final rule.
Mhm.
We're not going to be here. I'm not
No,
going to
right.
tell
I don't even want to go through 500
right.
pages of knowledge.
But there's a couple of key
Okay.
high level changes that happened
Mhm.
here. Okay. And the one is, if you remember that conversion factor,
Yeah.
that takes the RVUs and makes them into dollars. So the first thing is that CMS came out with just a new announcement for 2026 and said that they're going to break that conversion factor and make it more granular. And they're going to basically provide physicians that participate in an alternative payment model. They're going to give them a little bit of a kick, and I'll explain why in a
Yeah.
second. And then those that don't participate in this alternative payment model, they're going to get a little bit less.
Hmm.
So what is that? The alternative payment amount is just a fancy term to basically say if physicians enroll in some sort of risk-bearing
Hmm.
model, that might be an ACO or
Hmm.
other sorts of things. And as you may suspect, or your audience knows, is that has been the theme of the Affordable Care Act
Hmm.
for over 10 years now, is that they're trying to push physicians to enroll in these affordable alternative payment models
Hmm.
because they believe that's the key, whether they're right or not wrong,
Yeah.
to reducing overall healthcare costs. So that's number one. And I know I'm
Hmm.
being a little bit
Well,
long-winded here.
no, it's
Oh,
okay. But I do have a question.
yes, go ahead,
If
sir.
if a physician uh, conducts part of his or her practice through some ACO, but other parts not, are they I think the term is a QP, a qualified provider or something
Right,
like
right,
that,
right, right.
in general, or just in
No,
respect of what's flowing through the alternative program?
exactly
Okay.
the latter. So
Yeah.
if you do th yes, you're not upholding to one. If your services that you're providing
Mhm.
happen to be in an alternative payment model, then you would get that higher conversion
Yeah.
factor. And you could do whatever you want, of course, and you might be providing services that are outside of it.
Yeah.
So yeah, you're not
Okay.
just categorized as one or the other.
Got it. Okay. That's interesting. Okay.
Yeah.
So will physicians sort of in general receive increases from Medicare
So
next
yeah,
year? And what are those, at
right.
least, at
So let
least as of now?
Yeah. So let me finish there. So there's another, so that was that whole conversion factor.
Yeah.
And now, if people have remembered the big, beautiful bill, there
Yeah.
was something that was really helpful to physicians and contained in that bill. And they basically said that they're going to provide physicians, they're going to boost up these conversion
Hmm.
factors by 2.5%, which
Okay.
is start in 2026, which is great. So when you put, so those are the two things. So they separated out these
Okay.
conversion factors into those that are in these payment models and those that aren't.
Okay.
And then they said cross the board increase of 2.5% for everyone.
Okay.
Great. So what that results in is about 3 point, call it 8% increase for those that are enrolled, physicians that are enrolled in an alternative payment model,
Okay.
okay? And then a little bit less, 3.25-ish percent, call
Hmm.
it, for those that aren't.
Okay.
So, but now I think you're where you may be getting at. Does that mean that everyone's going to be getting a
Yeah.
3% change?
Yeah, I think from your face, I think the answer is no.
Yeah,
Yeah.
yeah. The devil's in the details, as they always are in these type of things. So if you recall, you got two things. You
Yeah.
got those
Uh-huh.
RVUs and you got those conversion factors. The conversion factors are going up about 3-ish percent, right? Well, what do you think CMS did with these
Yeah,
RVUs?
they're probably going to go down
Yeah.
because I've seen
So
this before. Yeah.
yeah, so you've seen
Yeah.
that before, and so it's kind of like the shuffle game with the ball under the
Yeah.
shelf, the shelf. So this one has got some increases for you, but this one not so much. So the RVUs, what did they do to these RVUs? Well, again, you got to step back and say, what is the mission of CMS? Well, it's to administer the Medicare and Medicaid system. I get it. But they're also, one of their big mandates is to try to reduce healthcare costs, which
Hmm.
we know are skyrocketing,
Yeah.
right? So what they did is they basically felt that certain physicians were getting over reimbursed and other physicians weren't. And more specifically, they felt that physicians that were performing what they called non-time-based services
Okay.
So that's basically your surgeons,
Mm-hmm.
right? They're doing procedures.
Mm-hmm.
Surgeons, yeah, well, that's the one that comes up to mind. And they provided them with a 2.5% decline on RVUs based on what they're calling an efficiency adjustment. So the long story short is they did some analyses and they felt
Mm-hmm.
that certain physician specialties were getting over reimbursed
Mm-hmm.
and that there's more technological advancements out there
Yeah.
that are making these surgeons and other certain
Mm-hmm.
providers more efficient, and therefore we got to reflect that. And so they've reduced those RVUs that I talked about in certain instances. Now, that's not across the board. So, on the flip side to that, are those physicians that are predominantly sit in offices and are, so you could think of family care
Mm-hmm.
physicians,
Mm-hmm.
psychiatrists, psychologists, social
Yeah.
workers, the list goes on and on. They got bumps in
Yeah.
reimbursement in their RVUs.
Mm-hmm.
So that is one of the two major changes that they made
Mm-hmm.
that kind of reduces the
Yeah.
RVUs, yeah, that offsets those other
Right.
instances.
It's interesting. Uh, as you were explaining that and the reduction in RVUs due to efficiency, it's almost sort of humorous in the sense that um, the concept of value-based care, which I always said was just three words, value-based care. That's all they meant was value-based care, as opposed to actually pricing based on value, because if somebody became more efficient at performing something that benefited a patient, the value to the patient didn't change. But apparently it did in the
Right.
number of RVUs. So,
Right. Yeah.
anyway, it just
Yeah.
helps support my argument. Anyway, uh,
Yeah.
how about what other sorts of, major changes are coming to the fee schedule?
So again, the second one was I keep holding up my fists here, but
Yeah,
I
yeah.
think it's good to kind of
All
show
right.
my little
Yeah.
graphical that you got your conversion factors
Right.
and you
And
got these
reimbursed.
RVUs. This is going up, these are going down.
Right. Right.
So the other prong to the RVUs that unfortunately this is a change that CMS made that's pushing reimbursement down is that they made changes into the physician expense RVUs.
Okay.
This is where physicians get compensated for overhead for
Hmm.
their practice. Again, you think of clinicians, nurses, CNAs, whatever, all that other administrative
Hmm.
staff, right? Well, CMS, crunched some numbers and they basically found out that certain physicians, predominantly surgeons again, were getting reimbursed for overhead for having multiple offices.
Hmm.
So they might have an office inside the hospital, right? Because that's where they perform their procedures. And they might have an office outside of the hospital to see their patients
Okay.
afterwards, right? So they did some, for better or for worse, they did some analysis, hired some studies, and they basically concluded that a lot of those physicians that were practicing in hospitals are only really maintaining one office. And so therefore, they're now only going to be reimbursed for one office, for one set of support clinicians, and so on and so forth. And this kind of goes along with the general overall macro trend in the healthcare industry where more physicians are now basically employed by hospitals
Hmm.
and they're working either in hospitals
Right.
or in the parking lot of hospitals, which are, an adjacent building.
Right.
Long story short here, the physicians that are facility based, again, I keep using the surgeons as an example. It's the low-hanging fruit here. We'll see their practice expense RVUs decline by roughly in half to those that are office-based physicians. And I'm going to continue to use the example of your
Hmm.
family care physician
Right.
that, never goes in the
Huh.
hospital.
Wow, that's
So
interesting.
those are it's a long-winded answer to basically and there's actually more changes, but those are the main
Hmm.
high-level changes that occurred with this announcement.
Right. But what about, I mean, you mentioned, surgeons as as sort of a broad a
Hmm.
group of specialists, but are there certain specialties that are getting sort of whacked more or lifted up more in
Of course.
2026?
Once again, devil's in the
Yeah.
details. And for guys like me that get into the details, you look at that 1,000-page document
Mhm.
that CMS comes out with, and there's one chart in the back, and they put it on page, I'm making this up, 959 page. And it actually details the net, what all the stuff that I basically
Mhm.
talked about, they come up with estimated impact to what Medicare reimbursements will go directionally for each and all
Okay.
specialties that are paid under the physician
Mhm.
fee schedule. I don't know offhand, but I got to think that that chart has got about 75 different physician
Mhm.
specialties and not in clinician specialties. People may want to reach out to me. I could show you where it's at. And then it basically breaks it down into the compensation, the change in compensation
Mhm.
that that specialty might receive if they administer their services in a facility
Mhm.
versus if they administer them outside a facility.
Okay.
And then so you've got for each specialty, you got three different numbers. You got the overall average,
Mhm.
you got what they would have gotten if they do it inside a facility,
Mhm.
and then if they do it in an office setting.
Okay.
Long story short, that may be getting into a little bit more of the details, but the winners,
Mhm.
the ones that will receive the highest
Mhm.
increases in reimbursement for 2024 are the ones that you might suspect that basically focus on time-based services in an
Mhm.
office. Who is that going to be? Like I said, your primary care physicians are going to be
Yeah.
getting about a 3% bump, which is good this day and age.
Yeah.
Allergy or immunology, help me out
I
there.
can't say that. I can't say immunologists without.
Immunology,
Yeah.
sorry.
Same thing.
7% bump, right?
Wow. That's significant.
So endocrinologists,
Yeah.
3%. And clinical psychologists, 3%, which we'll talk a little bit more about behavioral health and clinical
Yeah.
psychology later on. But those are to kind of give you
Mhm.
an idea,
Right.
those are the gainers, the big gainers.
Right.
And then and I'm actually going to actually caveat this, is that I know we're going to talk about in a little bit farther down about anesthesiology's
Yeah.
reimbursement. And so I'm going to put that as a sidebar for
Mhm.
right now.
Okay.
Because we're going to talk about it in more detail.
Yeah.
The ones
Mhm.
that you're going to see that are going to tend to be, see declines,
Mhm.
not surprising. Neurosurgery,
Mhm.
-5%. Gastroenterologists, -4%.
Mhm.
Orthopedic surgeons, -3. Cardiac surgeons, -3. And thoracic surgeons, about -3.
Jeez.
And then I've got one, I don't mean to rain on everyone's parade here, but there is another very material update that was included in
Mhm.
this. And that is those physicians that frequently administer skin
Yeah.
substitutes.
Is that based in part upon the huge amount of fraud in
Yeah,
wound care? Because
yeah,
this is something that I
yeah,
wrote about on the blog at
yeah,
weisspc.com, and I've seen in connection with client encounters. Uh, you to talk about that because you
yeah,
know the wound care fraud thing has been
yeah.
tremendous.
Well, being a forensic accountant, I don't like to say I use the fraud word loosely, but I get what you're saying. They're not. There has been probably an overuse
Mhm.
of skin substitutes or skin grafts
Mhm.
as of late. And what has happened, big picture, to kind of put some numbers to it, I saw this, is that CMS spent about $250 million in skin substitutes in 2019.
Mhm.
Do you have any idea what it's in 2024?
No, but
Well,
I'm probably going to be shocked. Go ahead and do it.
yeah, over 10 billion. B.
My God.
And they said that once tw we're done with 2025, which we nearly are, they say it's probably going to be closer to 13 to 14
Jeez.
billion.
Jeez.
So what had been happening is that these wound doctors, these plastic surgeons, and so on and so forth, where maybe you could say we're overusing skin grafts. And these skin grafts were getting reimbursed at what they call at the biological stage of
Okay.
reimbursement, which basically means they were cutting edge technology,
Mhm.
right? And that they were being reimbursed at several hundred to thousands of dollars per
Mhm.
unit.
Okay.
And you may be administering several units on a patient.
Got it.
Okay.
Okay.
And do the math. And these surgeons were getting an enormous amount of money.
Yeah. Wow. Wow.
So, like everything, CMS caught on this. They couldn't,
Yeah.
saw from 250 million to over 200 to 10 billion, and they basically cut it to a blended rate of
Mhm. Yeah.
$127. So a big decrease in reimbursements for
Mhm.
those that use skin grafts, that being, podiatrists, wound specialists,
Mhm.
and plastic surgeons.
Do you have any idea how 120 some bucks or whatever it is relates to the cost of the graft material, the
Yeah.
substitute material?
I don't know. Other than that, that at that price point, your margins are pretty thin.
Well, yeah. I mean, if
Yeah.
yeah.
Yeah. I don't know
Yeah. This
offhand,
is
but
interesting.
yeah.
Yeah. I mean, because, from my perspective, I viewed, um, I viewed the skin substitute, wound care sort of, and I'll use the word scams, as the progression of it went from compounded pain cream scams
Mhm.
to wound care
Right.
scams.
Yeah.
Just saying it. I'm certainly not saying that everybody who's doing wound care is a
Right.
fraudulent,
Right.
practitioner, but I'm saying that obviously something was going on here,
Right.
and
Right.
the something has resulted in
Right.
significant prosecution.
Right.
So
Yeah.
anyway,
So we'll see, I'll
yeah,
be, with all that said, just being from a very factual standpoint,
yeah,
I think you may see a lot more of OIG investigations in the years to come
sure.
now that they've changed these, and they're
Mhm.
going to be basically looking at these podiatrists and, wound care specialists and saying, their reimbursement has declined tremendously. Something must have been going on beforehand. I don't know. I'm speculating, but
Yeah,
I'm there is a lot there.
it's interesting. Yeah.
Yeah.
Yeah, I've also seen business people who were um, managers or promoters or in non-corporate practice of medicine states, owners of practices focused on wound care, now quickly seeking to find other niches of healthcare
Yeah,
into
of
which to
course.
relocate.
Of course.
So
Yeah.
they're
You're gonna
they
find,
they might have had skin in the game, but they're
right,
looking to put their skin someplace else.
right.
Anyway,
No pun intended,
yeah, well,
but
I tried
yeah,
to pun, but it just didn't come out.
yeah,
What about anesthesia services? I mean, a number of
yeah.
people that watch and listen to these broadcasts are anesthesiologists. So,
Oh.
what in general could you say about anesthesia reimbursement? Medicare Physician Fee Schedule for 2026.
So I would over categorize it as more or less mixed results.
Mhm.
Okay. There's some good and some maybe not so good.
Okay.
Okay. Um, what do you want to hear? The first is that, okay, so overall, anesthesiologist, on average, everything putting is headed to basically a negative 1%
Okay.
decline in reimbursement for
Mhm.
2026. Okay. But that's an average, right? So you've got some physicians or anesthesiologists that if they actually perform their services in a non-facility setting,
Mhm.
which I don't know. Yeah, I
So you're
could
talking
think,
about office-based? I mean, there
yes,
is
yeah,
office-based anesthesia.
yes,
There's,
yeah.
you know,
But what I'm saying
not
is
much,
that's
but there
not the
is. Yeah.
vast majority.
No.
That's not right. So it does happen, but
Yeah.
that's a minority. They will see increases of about 7%
Okay.
in their reimbursement. So that's a great thing. That's
Mhm.
something to be positive about, right? But as we know, anesthesiologists predominantly focus their work in facility-based settings,
Mhm.
right? And so they are on average, reimbursements is going to decline about 3%. So
Mhm.
once you take into consideration volume and
Right.
procedures mix, the overall average is
Mhm.
about a 1% decline. Now, I gotta say, well, you have a lot of anesthesiologists that are listen to this, they may not be excited about that,
Mhm.
but in the big scheme of things, they I think that there's some things that they could be happy about as there's others, some of their peers are faring a little worse.
Okay.
Some that are better, but definitely I mentioned a few other, surgeons that are not going to be faring nearly,
Mhm.
worse than that.
Right.
So how did they, if I could kind of back up for a second,
Yeah.
that's the overall takeaway.
Okay.
-1% across the board. So what happened was is they got anesthesiologists have got hit from two fronts on that RVU side that we
Okay.
talked about. Number one, the RV, as I talked about, there's the CMS incorporated an efficiency adjustment, right, for non-time based because they think that anesthesiologists are becoming more efficient and they feel that they can reduce. I
I don't
don't,
know. Okay, keep going.
yeah. I know, I see you on your face that you're like, how do you, is an anesthesiologist becoming more efficient?
Well, if the giant bulk of their practice is facility based and
Right,
it's perioperative care
right,
and Surgeon Smith starts the case and it takes 2 hours,
right,
there was a procedure code, there was a time code, a time element,
right,
and maybe some modifiers. I'm no super expert in anesthesia building, but I'm
right.
thinking, well, man, how much control did the anesthesiologist have over time? And the answer
Yeah,
is, I can't see where they hit
yeah.
any. But
And I agree with you. I
yeah,
agree with you. And I can't really think of what these efficiencies that
yeah,
anesthesiologists are
mm,
materializing. But it is what it is.
yeah,
They got impacted by that.
hmm,
The other one is the practice, like I talked about, having multiple offices and
Hmm.
all that. I could kind of, that's more intuitively makes a little bit sense to me. You know, most anesthesiologists practices in a facility in a hospital. Not all of it, I
Yeah.
get it.
Yeah.
But so they got hit by the practice expense changes. So that is the granular details and how you get to this basically -1% decline in reimbursement.
Interesting. Okay.
So,
All right. So let's shift then from things that are going on with a patient in a hospital to things that are going on where a patient's at home or at work
yeah.
or driving in their car, as in telehealth. So what
Well,
about telehealth in 2026?
telehealth. So CMS made some what I think are very positive changes in the telehealth world. Big picture. Telehealth was never, because I studied these things, was never really reimbursed all that well.
Hmm.
Before the pandemic, you could
Hmm.
only get it in real rural settings,
Yeah.
right? Made sense, right? Because they, CMS kind of thought of that there would be a lot of fraud and abuse, and rightfully
Hmm.
so,
Yeah.
probably, if you
Hmm.
lay it out across the country,
Yeah.
right? Then the pandemic came
Hmm.
and people love their telehealth,
Yeah.
right? I do, everyone does. It doesn't mean, and so it really shuffled in the
Hmm.
whole telehealth world, and they started and they embraced it, and they continue to kind of make telehealth more accessible
Hmm.
to everyone, and they kind of are making the rules and changes easier to get reimbursement for it. And I think overall that's a good thing. That's my personal two
Hmm.
cents worth. They do have to be mindful of, like of everything, of fraud and abuse, but
Hmm.
that's going to go on wherever you go in the healthcare world, right?
Hmm.
But the changes that they made is they simplified the telehealth policy by then making dramatically expanded payment. They basically eliminated this distinction between temporary and permanent telehealth services, which I won't get into the weeds to. And they basically removed time limits that they could only be get reimbursed for if you were seeing a patient that was in an inpatient hospital or in a nursing facility. They used to have time limits
Okay.
with it. They've removed those. So now you could get reimbursed for more if you're talking to the patient on a longer time period.
Okay.
I don't remember, I think it was 15 minutes before. If you're talking for a patient longer, you could get an additional incremental 15 minutes, so on and so forth. Long story
Hmm.
short, the changes that CMS made are definitely a net positive for the
Okay.
telehealth industry and are making it a stable, permanent
Hmm.
part of healthcare delivery.
That's interesting. Okay.
Yeah.
Well, since you mentioned it earlier, and since some people listening to this may be going crazy because their reimbursement's going down, let's talk about behavioral health access.
So another thing that kind of spanned from that stems from the pandemic
Yeah.
is you probably know, there were a lot of behavioral health issues during the
Mhm.
pandemic, and behavioral health clinicians were overwhelmed.
Yeah.
At every sort of end, people, you've probably heard the stories, people with wearing their masks 10 hours a day, and there's
Hmm.
just all sorts of different things going. So ever since the pandemic, CMS has really seen the need and they have really embraced and expanding
Hmm.
coverage for behavioral health and making more reimbursement codes possible for different behavioral health
Hmm.
services. And they've just been promoting access and doing all sorts of what I would say are positive
Yeah.
things. So with this recent announcement, they continued that theme and they basically finalized some new
Hmm.
add-on codes that I'm not going to get into all the details to it. They've made these codes more accessible for psychiatric care and not only
Hmm.
for psychology care.
Hmm.
And and so yeah, so it's there, and they're trying to kind of really actually increase reimbursement for it because I think there's a
Mhm.
long embedded belief that some of these clinicians may have been under reimbursed
Mhm.
over the years.
Mhm.
And you see, actually, as I explained earlier on,
Mhm.
that behavioral health is, are actually on one of the higher reimbursement ends. They benefit most from
Mhm.
this recent reimbursement and getting a roughly 3%
Mhm.
increase, which is good in this day and age.
Well,
So yeah.
right. Well, I think this has been very interesting. I mean, for me at least. Um,
Mhm.
um, I I don't know whether I feel that knowing more has helped me understand what's going on inside of CMS's black box, or whether I'm actually more confused and I'd rather somebody like you think about what's going on inside of CMS's
Yeah.
black
Yeah.
box. I just know that uh, on the expense side for many of my physician group clients and solo doctors that I represent, that their expenses are going up through the roof. They at least see things as continuing. There's continuing pressure on them in terms of they would see it as overall downward reimbursement
Right.
on the commercial side, which we're not even talking about. Although I guess there is, to the extent that CMS reduces the number of RVUs and commercial payers are looking at CMS's lead in terms of the number of RVUs being assigned, right? You impact negatively
Mhm.
commercial reimbursement in a way at the same time,
Mhm.
whether intentionally or unintentionally. But
Mhm.
I suppose that's another story for another day. So,
Yeah. The
but
only thing I would
yeah,
conclude upon it is, and I get you loud and
yeah,
clear, this is a lot of minutia of details, and
yeah,
then most people, clearly the physicians don't have the time or effort to do it. But I think, it's
yeah,
important. It's how you get reimbursed.
yeah,
And as we know,
mhm,
commercial payers tend to file Medicare at the
yeah,
end of the day.
yeah,
And while the devil is in the details, there's always going to be, and I'm going to loosely define it, loopholes or ways that you could kind of repurpose your practice
mhm,
to get some more of the physician and services that are out there that may be more highly reimbursed.
mhm,
As an example, the wound care
yeah,
services, that may be an extreme. They
mhm,
worry there's probably some instances of overusing
yeah,
skin substitutes. I get it. But as you could kind of see, podiatrists and wound care specialists for the longest time weren't highly reimbursed,
yeah,
but they kind of found something there.
yeah,
Now, whether, putting everything
mhm,
aside here,
mhm,
which we're kind of implying, and it's they could have legitimately found things that were more higher
yeah,
reimbursement that augmented their
mhm,
practice for better word. And
mhm,
I would suggest that physicians that may be listening today and anesthesiologists and so forth, you may want to speak to someone because
mhm,
the devil is always
yeah,
in the details. And these are just macro level averages that I provided
okay,
out here.
got it.
And it might be something to kind of look at too.
Well, that ties things up nicely because what I'd like you to do is let people know how they could get a hold of you. Not only to ask you on what page they could find the specialty
Yeah.
specific information that you mentioned in the 1,000 page regulation here,
Right.
but to just to get in touch with you. I mean, clearly, uh, I think that physicians in practice should look for ways to legally, and we'll say legally 3 times, legally, legally. Now we've done three. Uh, increase their compensation, as as legally permissible. We don't want them to become fake wound care specialists. So to get a hold of you, how would somebody reach out to you, Jason?
Sure. I'll give you my cell phone
Yeah, go
number. I'm
ahead.
always available. 773. I'm a Chicago-based guy. That's where you get that.
Okay.
791-5810 is my direct cell. Happy
Hey,
to
do me a
talk,
favor.
speak with
Would
anyone.
you repeat your phone number? Because
Yeah,
at least at this end, it lagged a little bit. So start from
sure.
the top.
773-791-5810. And I will give you my email address, but I'm going to forewarn you, it's a long one, and I'm working on getting it a more simple one. So it's J as in Jason, Almiro, spelled Almiro, at quantumhealthadvisors.com. It's a long one.
That's all right.
But maybe if people on here obviously have Mark's information, you could pass it along to me. Happy to help and to speak with anyone that may be watching this in any sort of way or capacity. Cell phone's probably easiest. I'll say one last time, 773-791-5810. Thank you so much for
Yeah,
having me.
thank you for being here. I learned a lot. As I mentioned, this is an area that I'm honest that I know very little about, and I appreciate your expertise. I will have my assistant include your contact information in the little notes that appear certainly on YouTube, where most people consume the broadcast. And again, thank you very much, and I look forward to speaking with you again soon.
It's my pleasure and happy holidays
All
to you
right.
and your
Thank
audience.
you. All right.
Good.